Hello and welcome to Single Payer Radio. I'm Paul Hoppy, broadcasting from the Hayburn Building in Louisville on WFMP 106.5, Forward Radio Community Network, where news, information, and entertainment is available 24 hours a day, 7 days a week. The views and opinions expressed on our show are those of the speakers and not the station. Single Payer Radio is a project of Kentuckians for Single Payer Healthcare, in conjunction with Physicians for a National Health Program through its Kentucky chapter. We produce this program because we believe healthcare is a human right. We advocate for a national, not-for-profit, publicly funded, single-payer healthcare system, also known as Enhanced Medicare for All, covering dental, vision, hearing, prescriptions, mental health, and long-term care, covering everyone starting at birth. Catch our programs at 2 p.m. Monday, 7 a.m. Tuesday, and 11 a.m. on Wednesday. We also stream our show on SoundCloud, Apple Podcasts, and others, so you can listen anytime. And remember, this is an all-volunteer radio station and relies on your ideas and donations to keep us on the air. Today, Drs. Mike Flynn and Gene Shively join me as co-hosts with their special guest. Let's get started. Dr. Flynn?
Yeah, this is Michael Flynn, retired surgical oncologist from University of Louisville Surgery Department. Let me begin with the usual disclaimer. Any comments I make represent my personal views and do not represent the views of the Department of Surgery or the University of Louisville. Gene?
This is Eugene Shively. I'm a retired general surgeon in Campbellsville, Kentucky. I've spent my whole career in rural surgery and have had a close relationship with the Department of Surgery at the University of Louisville. Anything I say represent my opinion and not the University of Louisville or the Taylor Regional Hospital.
So our program topic today is opioid use issues and access to buprenorphine, which is a drug used to treat opioid use disorder. And we have a very special guest today, James Patrick Murphy. Dr. Murphy is the CEO of the Murphy Pain Center in New Albany. He got his medical degree from University of Louisville, did an anesthesia residency here at U of L, did a pain management fellowship at the Mayo Clinic, and he has a master's in medical management from the Marshall School of Business in California. And he's been an advocate for the holistic approach to addiction issues and increased access to buprenorphine. And he's going to explain what that drug is and how it's used to our listeners. Before I allow him to make whatever comments he'd like to make, let me challenge our listeners to double-check the comments that we make. And there are multiple sources, information sources on Google, the Journal of the American Medical Association, New England Journal of Medicine, Wikipedia. There are 2 articles on opioid use and buprenorphine in the Journal of the American Medical Association on the 17th of March and the 5th of May. So, Pat, thank you for coming on. We appreciate your willingness to discuss these important issues for our listeners. And as we have done in the past, we're going to give you an opportunity to make whatever comments you'd like to make for as long as you'd like to make them. And Gene will begin the conversation. So the floor is yours.
Well, thank you both, and thank you to the organization for allowing me to be on your program today. And by the way, I want to tell you that's a very dangerous thing to give me a microphone to talk as long as I want to. So I've been told
well, that's okay. We can always cut you off if we need to.
please, you have my permission. Please do that. But I'll try to keep as salient and as pertinent and as brief as I can to the comments so that we can get through some questions as well. And I do appreciate this opportunity. I want to do a disclaimer also. I am a professor gratis, which is one of the volunteer professors at the University of Louisville School of Medicine. And I also serve on the board of the American Society of Addiction Medicine. I am a doctor licensed in Kentucky and Indiana. I'm really a pain specialist, but I'm also a specialist in addiction medicine. And I want to be clear that the comments I'm making today are my own opinions and should not be ascribed or given to any other organization. But that's my background. So with that being said, I wanted to talk about this issue called buprenorphine. It's kind of a fun word to say if you've practiced saying it, buprenorphine. It goes by, some people call it bupe. Some people call it by its trade name. Suboxone is one of the more common trade names for this, but it comes in many forms. There's an injectable version of it. There's a once-a-month injection of it. It's a medication we also use for pain management in the operating room sometimes and in the emergency rooms. It's kind of an opioid, but not a full opioid. It's kind of a partial opioid. So it's kind of a morphine type drug, but it's got a little bit of a ceiling effect to it. And so it's a bit safer than a lot of the other opioids that we know about. The reason why it's so important to talk about it now is because it is honestly, by research, if not the best, perhaps the best tool we have to treat this condition called opioid use disorder. And in fact, it's probably the best medicine we have to prevent overdoses from opioids. And we have this opioid crisis in this country. We've had it for decades. We've had this overdose crisis with deaths skyrocketing and around the country, and certainly in our state as well. Kentucky has one of the most difficult and tragic, if you will, opioid crises with overdoses. And this medication is extremely effective compared to other measures in terms of preventing death and actually treating the disease of addiction. Now, the reason why we need to talk about it is because it's really underutilized. In many states, and certainly in Kentucky, it's underutilized. And there's some reasons which we'll go into as to why that is. And part of the reason why I'm on your show today and advocating about this is because I'm a Kentuckian. I mean, I know people that have had addiction issues. I have some patients that have, dealt with this medical illness, and people in my neighborhood, in my community, and every family, everyone knows somebody probably, or knows of somebody who's had an issue with opioids at some point. It's just very common. It's across the board. You're not going to just see it in certain communities or inner cities or rural areas or certain parts of town. You're going to see it everywhere because it really affects every community, every walk of life. So it's something we can all get behind treating, especially when we have this really effective medicine. So before I get into a bit more about why there are barriers to getting it, let me explain what it is. It's not methadone. We've heard of methadone clinics before, where people that have opioid addiction will go typically once a day and they'll get a dose of methadone. Methadone is a very strong, potent opioid or narcotic-like medicine. It's very long-acting. So people with addiction can generally take it once a day, and it really helps with the cravings and the preoccupation and the behaviors that lead them to maybe use heroin or other drugs throughout the day. So it stabilizes the part of the brain that creates that behavior. That's methadone. Methadone, it's pretty easy to overdose on methadone. I mean, opioids can kill you a number of ways, but the main way that an opioid will kill you is if you take too much of it for you and you stop breathing. And that's why people have Narcan. Narcan is the antidote to these opioids. It's a very brief medicine that usually people squirt up their nose. It's a nasal, generally speaking, but you can give it other ways. But the Narcan will reverse the effects of the narcotic or the opioid. So in the case of somebody overdosing on an opioid, like whether it be methadone or heroin or morphine or anything like that, if they overdose and stop breathing, you can give them the Narcan, and that reverses it, and they start breathing again. If the opioid was the cause of the not breathing, it can reverse that. Now, sometimes with the potent opioids out there, we've heard of fentanyl being such a problem. Fentanyl is a very extremely potent opioid. So even a small amount could make somebody stop breathing. Fentanyl is both abused and it's also, I say, secretly, clandestinely put into the illicit drug supply. So somebody might think they're getting heroin and they're used to heroin, which is bad, but not as potent as the fentanyl, but they get fentanyl instead, or part of the drug has got fentanyl. Now they stop breathing. And so you have to, if you find somebody like that, you give them Narcan, you can reverse it and they can get breathing again. And that's been a major important plus for our country and certainly our state. I think we've saved a lot of lives by having Narcan. And Narcan is kind of like an epinephrine pen, an EpiPen. When somebody gets a bee sting and they're allergic to it, you can give them the epinephrine and then it kind of treats the anaphylactic shock and saves them. So it doesn't treat the allergy, but it can save them. Well, that's the way Narcan can bring somebody back from near death or certain death, get them breathing again, but it does nothing to actually treat the disease or what actually caused the overdose. Okay? So it's like also somebody has a heart attack and they drop down in front of you and you call 911, then you get the defibrillator, that machine. You put the pads on their chest, on their back, you defibrillate them, and if things go well, you get their heart beating again, and you save that person. Yay! Okay, we've saved somebody's life. Their heart's beating again. But what do we do? What do we do to keep it from happening again? And usually they have to have follow-up care, and they get medicines, and their heart is looked at. And that's kind of the way it is with buprenorphine, methadone, and then this disease of addiction. This opioid addiction, leads to these critical issues where people overdose. But the Narcan doesn't treat the cause. Well, we have three FDA-approved drugs that can treat addiction, FDA approved. One is actually a kind of a cousin to the Narcan. It's a trade name Vivitrol. It's not naloxone. But it's a similar drug to the Narcan, and it's an injectable, once a month injection usually. And that's for people that are already in recovery, meaning they're stabilized, they're not using, and this helps them curb some of the cravings and stay in recovery longer. And it's an okay medicine, and for some people it's very, very effective. But it doesn't hit the receptors like the other two drugs, which are methadone and buprenorphine. Those two drugs, methadone and buprenorphine, are not like Narcan. They are actually in the opioid family, and they go right to the part of the brain that's been damaged by the addiction. They, in a sense, balance that part of the brain that's almost like having a stroke. It balances out the chemicals in that part of the brain. One of the chemicals that's important there is dopamine, but there are others as well. But it balances it out so that now the person with addiction is thinking more clearly. They're calmer. They're functioning better. They're able to make better decisions. Also, some of these uncomfortable side effects, the withdrawal syndromes or the cravings, things of that nature, are taken care of to a large degree. So it allows people to go on with their lives and function, go to work, have families, attend church, do whatever they need to do, go on with their lives. So it's a really, really important medication that we have available. So methadone, being very potent, being very powerful, methadone has to come from a methadone clinic. They are highly regulated, they are certified, and it's a clinic that really does methadone. And so there's lots of rules and regulations, and it's very strict about that. We can discuss, another time whether, those need to be changed a little bit. But there's a reason for that. Buprenorphine, on the other hand, as I said earlier, is not a full opioid. It's a partial opioid. And buprenorphine, unlike the other opioids, has what we call a ceiling effect. In other words, for somebody who is basically tolerant to opioids, they've been using them for a while, maybe they've been using heroin or whatever, if their body is tolerant to opioids, which is a natural occurrence with people that use, then it's almost impossible. I won't say impossible, but it's really hard to overdose on buprenorphine. It's hard to stop breathing taking it. That doesn't mean it's like perfectly safe, but compared to methadone, buprenorphine is so much safer. And by the way, buprenorphine doesn't have to come from a buprenorphine clinic. You've heard of Suboxone clinics or addiction clinics. The DEA has lessened the restrictions on buprenorphine because they've seen it to be so effective. The federal government has lessened the restrictions on buprenorphine. Buprenorphine is a Schedule III drug. Most of the stronger opioids are Schedule II, meaning they're more potent, but a Schedule III drug is considered maybe less addictive, less of a problem. It's not always true, but in this case, buprenorphine is a medicine that can actually be called in over the phone. You can give refills on buprenorphine. Buprenorphine is like any other Schedule III drug that your doctor might give you. So it really can come from a doctor's office. It doesn't have to come from a Suboxone clinic. Your primary care doctor is authorized to prescribe it. In fact, your dentist is authorized to prescribe it. Anybody now in this country with a DEA license, which most physicians and dentists and even podiatrists, most people that can prescribe controlled substances, in fact, all of them have had to have training in how to prescribe and how to use buprenorphine. And the reason they do that is so that at the primary care level, that your providers would feel hopefully comfortable at least starting somebody on this medicine. For example, say I'm your primary care doctor and you come in with me with a bad back and I give you, say I give you Percocet, which is oxycodone. That's a very common opioid that we give people for moderate to severe pain. It's not for long-term use generally. But say my patient comes back in 2 weeks and says, hey, I'm out of my meds early. Actually, I was chewing them and I actually bought some more off the street because I was really hurting and then I kind of liked it. I kind of liked the effect it had on me. While I'm thinking as a primary care doc, I'm thinking, okay, maybe you have a genetic predisposition to becoming addicted to this. Maybe there's other issues going on here. Maybe there's a problem with you taking this medicine. But I don't want to just cut you off. I think what I'll do is perhaps start you on a medicine that could maybe help your pain, because buprenorphine does help pain, but also something that will maybe calm down that craving area of your brain and get you on more of a stable aspect. I'm not an addiction specialist doing this, but I can understand, since I prescribed you the medicine, I want to be able to treat it. Okay, and this is just like if I was a surgeon, and I know you both of you there are surgeons, and if you have, if you're not infectious, I don't think you're infectious disease specialists, but if you cut on somebody to try to help them, and they come back a week later and they've got some redness around the infection and maybe a little bit of pus there or whatever, and you say, okay, it looks like you got a superficial infection here, something going on. I'm going to go ahead and treat you with some Keflex or penicillin or ampicillin or whatever I'm going to treat you. I'm going to treat you with an antibiotic, see you back and see how you did, as your surgeon. In other words, you did something to help the patient. There was a side effect or an outcome that you didn't really want to have happen, but it happens rarely, hopefully. But you're going to be able to treat that complication. Same thing with Suboxone. If I were to give somebody Percocet for their low back pain and they were developing what may be a problem opioid use or maybe an early signs of addiction, not being a specialist in addiction, I'd like to be able to treat them. I'd like to be able to go and get them started on something. Maybe it'll take care of it. Maybe it won't. But at least I can calm them down and get them into more of a safe use of the medication. And maybe they do need counseling. Maybe they do need to go to an addiction specialist somewhere and talk about why this happened. But it needs to be something available at the primary care level. Okay, I hope I've made that clear enough. So what's the problem in Kentucky? What's the issue here? What's the problem? Why are we having this conversation? If it makes so much sense, if even the our government in Kentucky says that the use of buprenorphine can lower the overdose death rate by 50% or more and save lives, if that's information coming from our very government officials in Kentucky and around and federal as well, but Kentucky has said this, why is it not so available in Kentucky? Well, that's a good cause. That's why we're having this conversation, because it should be more available. I mean, it's if we have an epidemic of opioid overuse and death, we should have available the medication that we know is best to treat it, right? So the problem is there's a lot of stigma out there. A lot of people, I've heard this a lot. Well, I just don't like trading one addiction for another or one dependency for another. And I think what they're saying there is it's not a good idea to just take somebody who's addicted to opioids and then put them on another opioid. And my comment to that is, well, that's not really what we're doing. What we're doing here is we're treating the actual disease process. As I mentioned, there's a disease process in the brain causing the opioid addiction, and we are giving medication that we know from research, from years of experience, is highly effective at treating that condition.
Pat, let's broaden things a little bit and maybe get into some broader issues about opioid use disorder. Gene, you want to start the ball rolling?
Yeah, you described the patient that may need to go on Suboxone. Let's say the primary care physician starts a patient on Suboxone. How long will they have to stay on it? And then what's a relapse rate of people on Suboxone going back to opioids like Lortab and other opioids?
Well, I think that it varies with the individual. Some people, it might be as little as a week or so. It might be just maybe a few days to get them, down off the medicine they're taking. So it treats their withdrawal symptoms. It might be longer. It might be months. And for some people, it could be years. And for some people, it could be a lifetime. If you truly have damage to the brain that's causing that addictive behavior, then you might need the medicine for a long duration. Kind of like how we treat diabetes, for example. Somebody comes in your doc and you've got a high blood sugar and your A1C's, really high, and they say, you got diabetes here or pre-diabetes. Let's see if we can treat you here. I'm going to give you some insulin, some medications, get your blood sugar down, but I also want you to, lose weight, exercise, to eat well, those things as well. And then when they follow you up, hey, your blood sugar is normalized here. Maybe you can come off some of this medicine. And I think that it varies from person to person with diabetes. Sometimes your body doesn't produce insulin, and so you're going to need it really the rest of your life. And addiction is kind of the same way. I think it just varies from person to person, but generally there's two types of people that use this medication. One would be somebody that needs to wean or taper down off the opioid they're on, and it can be helpful for that. The other is the person who truly has the disease of addiction, and that could be anywhere from 6 months, few years to a lifetime on it. And we shouldn't stigmatize people. We should allow people to work with their physicians and their caregivers. And actually, if you're somebody who needs to be on this medicine, if you function well on it, if the benefits outweigh the harms, then you should be allowed to stay on it and not feel guilty about it. So that's the
Can
answer.
you give our listeners a kind of an overview about opioid use disorder, one, in the country, and two, in the state of Kentucky, just to kind of set a little groundwork so everybody has an idea. Is it getting better, getting worse, the same, both in the country as well as in the state?
Okay, well, let's go back to the 1990s. So in the 1990s, we had this really push to treat chronic pain, for example. We've always had an addiction issue in this country. At various times of the year of the century, it was stimulants like methamphetamine or cocaine. Then it became heroin. Then it became other medications. Well, in the 90s, it was really driven by prescription opioids. So there was you've heard about the pharmaceutical companies over marketing these things and this push, this perfect storm of pushing people to treat chronic pain because it was so prevalent. Well, there was a lot of what we call overprescribing. So there was a lot of these pills out in the market and in the community, and people just started, abusing them, and that created this opioid crisis driven by the pills. And then around 2010 or so, the evidence was there that the pills were kind of driving this. So regulations became put into place, and they really worked to lower the amount of pills that were prescribed to people. But what happened was, as the prescription pills became less prescribed, other agents moved into the market, and I'm talking about heroin and fentanyl. So what happened was there was a need or a demand for opioids for people to abuse or use or whatever. And since the pills dropped off, then the more unregulated illicit opioids took over. And that's carried on till today. So the opioid crisis today is really no longer driven by the prescribing. The opioid crisis today is driven by the illegal fentanyl and heroin that comes into the country and comes into our drug system. And it's more potent and obviously more unregulated. So that's where we are now. The overdoses have been rising probably for the last 50, 60 years. That they really spiked up interestingly, when the prescribing for pills dropped down. They dropped like 50%, but the overdose death rate doubled during that time. I'm talking about the 2010 to 2020. So why did the overdose death rate double when we were actually decreasing the pills prescribed? Well, it's because we weren't treating the actual disease of addiction. What we were focusing on is pills, the agent. And what happened was when the pills dropped off, something else moved in. And that's kind of where we are now as well. We saw a big peak during COVID. COVID, people lost access to their providers. They couldn't get care, couldn't get prescriptions, couldn't get what they needed. And also, there was a lot of stress in this country during that time. So the overdose death rate really, really peaked during COVID. And then it started to come down. And in fact, it's come down almost every year the last few years. And we had a nice drop last year as well. Almost a 30% drop in Kentucky and around the country in overdose from opioids. And it's really unclear exactly why that happened, but unfortunately, if you think about it, we're still at a higher level than we were pre-COVID. So we haven't really addressed the underlying cause of the overdose, which is the disease of addiction. And that's why we're out there advocating for this treatment for the actual disease of addiction. The opioid use disorder, the best treatment we have is a medication like buprenorphine. That's the absolute best medication we have.
Pat, I thought a lot about this and this data with the opioid deaths are coming down. And so, there's really not a good explanation, except the only one I can come up with is that Narcan is having such an effect today on keeping these people from dying.
Yes, Narcan, I remember back 10 years ago, you couldn't get Narcan without a prescription. And it was hard to, find it. We had harm reduction societies trying to, give it to people here and there, whatever. But, nowadays you go to the fair, Kentucky State Fair, and they're giving it to you over the counter. They're handing it out to you at the fair. And it's a good idea. You want to have Narcan available everywhere, so if you come across somebody, you think it's a possibly, an overdose, it's almost not going to hurt somebody. Again, there's no absolutes here, but Narcan is essentially a very safe drug to give somebody. And if it's due to an opioid, the overdose, it'll get them breathing again, usually. Now, sometimes the fentanyl is so potent that you got to redose the Narcan, and also it's so potent that it won't last long enough. So you don't cure somebody's overdose with Narcan. You may get them breathing again, but you got to be careful because they might stop breathing again. So you always call 911. You always do the emergency efforts there as well. There's also other adulterants, other drugs in the drug supply now. There's things like a drug called xylazine, which is like a horse tranquilizer. These illicit marketers, these people that make this, are always looking for things to put in the drug supply that either make it cheaper or more potent. And so xylazine is a sedative that is not reversed by Narcan. So I might get you breathing again, but you're still passed out. And so it's really a more complicated overdose crisis now than we've had in the past because of the adulterants in there. But that's kind of where we are. And I think that the fentanyl, honestly, has been noted to be less potent in the drug supply now. So I think that maybe the people that supply this to our neighborhoods and the drug dealers, the people that make this, they've decided that they want to quit killing off all of their customers in a sense. So they've made the fentanyl less potent, and but still, potent enough to where it can kill you in one dose. But I think that's part of the reason. And I think there is more. We are making progress in terms of access to care. There are more clinics, more people that are being open to this. Part of the reason why I'm on here today with this this program is that I'm just trying to hopefully people like myself in my the professional groups that I work with, we want to reduce the stigma of this, and if we can make the treatment of opioid use disorder similar to how we treat other medical illnesses, reverse the stigma, understand that this is something that nobody wants to be an addict, nobody wants to be addicted to these things, but they want treatment, they want care for this disease. If we approach our patients like we would approach any other disease, I think that we would really make the progress we need. Currently, there's a lot of stigma behind it. There's a lot of misunderstanding about what this medicine really does. And that's educational. And this program is an example of how we get over that barrier.
Now,
Let me ask a question about people who have opioid use disorders and other that have psychiatric illnesses. Should a primary care physician be treating someone with opioid use disorder, and then if they have a patient who has severe depression or let's say they're schizophrenic or bipolar, should they add other medicines like antidepressants and drugs for schizophrenia and bipolar? Should they do that, or should a psychiatrist or a specialty clinic do that?
I think that depends upon the comfort level of the provider. Some internal medicine, primary care providers, pain specialists even, so they understand and they feel more comfortable treating those conditions. But we call those co-occurring conditions. For example, a lot of people that have lung problems, COPD, they also have heart problems. The lung bone is connected to the heart bone. They're two different conditions. And, I might feel comfortable treating the pulmonary, the lung problem. But as a primary care doctor, I might say, well, I need a cardiologist to help me with the heart issue here, so that I make sure you get the best care possible. So we'd like for our primary care physicians and nurse practitioners and providers to feel like they can work within the level of their comfort zone, and they can decide if they feel like they can treat it there in the clinic, or if it needs a referral someplace else. It shouldn't be something that's mandatory or forced to by law or whatever, because a lot of this is, honestly, everyone's different, and you should be able to have a conversation or a relationship with your doctor or your nurse practitioner or somebody, and then you come up with a plan that works for you. Not everybody is going to want or even be able to go to counseling or go to a psychiatrist. So, if it's available to me, great, if I can get you in there. But what if your insurance doesn't cover it? What if you don't have transportation? What if you're actually living under a viaduct, down in Shawnee Park, down by there? That's where your life is right now. You have to meet people where they are and treat the most important, most life-threatening issues first. And then once you get that stabilized, move on to other things. But the scenario that you mentioned here, where somebody has a severe psychiatric illness along with the opioid use disorder, you're probably not going to be successful in either one unless you are treating both.
Paul's got a question.
Yeah, well, we had to cancel this program a week ago for unforeseen reasons, but I wouldn't have the story to tell if that hadn't happened. So this past Saturday, I visited a young fellow that I know who's incarcerated, and I believe I contacted you about this fellow because it was announced to him that the facility that he's at is going to have a Suboxone program running, and I told him that I knew you and I've heard your story a couple of times, and I think it would be great for him to do that if it's available to him. Well, when I visited him, he is now on that program. First of all, I maybe you can give me some background on why there is a program at these facilities. But secondly, he told me he's been on it a week now, and he feels completely different, which warmed my heart. And so that's why I think it was a good idea that maybe we did have to cancel the program last week. So I'd like to just hear your thoughts on that.
Well, first of all, I'm really happy that he's getting better. That points out that he's getting the proper medical treatment for his medical condition. And, people that are in the throes of addiction or if they're in, withdrawal from stuff they've been using, their brain's on fire. Their brain's on fire. And you can't think properly or even feel decent at all. You feel horrible. But that medication is like throwing water on the fire. It calms it down. It doesn't cure you right away, but it's treating the cause of how you feel that way. And I don't want to say it's a magic pill, but I've had patients before that I almost tell them like, okay, you ready for this? This is going to feel like a magic trick. You're going to immediately feel better. And if you do it, if you certain ways you do it, and there's various ways of initiating Suboxone or this medication, buprenorphine. But if you do it properly in the context of what you know about that patient, usually you can get a really good response right away. And I think that's important because that gets the patient then has confidence and they go, oh, there is hope for me. Oh, I feel normal again for the first time in forever. The reason why the jails are having it now, part of the reason is because there was a lawsuit by the federal government. And the issue was that opioid use disorder is considered a medical illness. It's a disability protected by the Americans with Disabilities Act. And so if somebody goes into a jail or a prison and they have a medical condition, then they have to be treated for that condition. That's the law. So a lot of jails then are bringing these programs in. Not all of them, and it's still a lot of stigma. There's still a lot of issues with this, still a lot of understanding. But that's humane, that's proper, and that actually decreases the recidivism. It decreases the crime when the person is released. If they can stay on this and have continuity of care, the relapses are less, the crime is less, all of the benefits you would see to society. So there's a really great return on that investment from a society standpoint. The problem is that people get out of prison where they're actually now getting some treatment, and they can't find somebody in their community to continue it. So they have to go, 100 miles to find a clinic that will give them this medicine, which they were getting while they were in prison. And eventually, maybe they can't make it or they miss an appointment, and then they get released from the clinic. And now they're back where they were. That's why it's so important that we have access to this medication, this treatment, legally in all of our communities in Kentucky.
Pat, give us an example of how access to this treatment is influenced by their coverage with either Medicare, Medicaid, or private health insurance. Does that affect the degree of access to care, or is it not an issue?
It's a major issue. It's gotten better over the years. There's a thing called prior authorization that most people understand. It's really annoying because if a doctor or prescriber wants you to have something, the insurance company is going to say, wait, we want to have it authorized before we pay for it. And so the doctor or the prescriber, the nurse practitioner, they have to send in all of this information and hope that the insurance reviewers who've never seen you ever, hopefully they will allow you to have this, what is actually life-saving medicine. And it could take days to get that back. Well, what's going to happen in those days you're waiting to get the medicine? Certainly if you had chest pain, they wouldn't, withhold nitroglycerin from you, hopefully, to treat the chest pain. But if you have addiction and I'm ready for treatment and I'm finally decided I'm ready to try this, and now I've got to wait 3 days or a week or longer, I'm probably going to go to the street and use again. That's what happens a lot of times. So the prior authorizations is an issue. It's still there. Also, there's limits on the amount of medicine that we're able to give people and the dosage. As I told you earlier, fentanyl's out there now. Fentanyl is so potent that you might need a higher dose of the buprenorphine than your insurance company is going to allow because of whatever reason they have. And you have to, work around that. Also, the formulation. You might be a perfect candidate for the injectable version that lasts a week or a month, and then insurance doesn't cover that, but they'll give you the pill or sometimes it comes in a film under your tongue, but they might only give you certain formulations of it. I may want a patient to be on 12 milligrams of the medicine. Well, Medicaid doesn't cover a 12 milligram, so I got to give them an 8 and a 4. Now it's 2 prescriptions. It's just issues that are really burdensome in terms of allowing prescribers to give patients what they actually need. And by the way, that titration phase early on is crucial. I have to be able to adjust the dosages to your needs. I might start you on a lower dose, but immediately want you on a higher dose, depending on how you're doing. But like any other critical care medicine, we have to be able to adjust the dosage. I'm an anesthesiologist. Whether you know it or not, when you're having surgery and I'm, fixing your blood pressure or helping you out under surgery, I give you a medication, and then I immediately look at the vital signs. I look at what's going on, and I can adjust what's happening depending upon what happened with the medication. And that's kind of what we have to do in addiction. We have to be able to give the medication and be able to adjust it. But these regulations that we have in Kentucky, these insurance regulations, these pharmacy regulations that we have really make it challenging for doctors to do that with their patients.
Well, these insurance companies are not in business to provide health care. They're in business to make money, and health care is just the vehicle for them to make their money.
Let me ask
Gene,
about
go ahead.
Medicaid. That issue is coming up at the end of the year. The great beautiful bill. They decided to cut back Medicaid the 1st of January 2027, and it's going to be a dramatic cut for Kentucky. There's more money coming in from Medicaid than the whole budget of the state of Kentucky. How is that going to affect the treatment of people who are addicted to drugs and their access to care, and particularly with Suboxone?
Well, from one perspective, Kentucky has a high number of beds in these facilities that when there was a lot of money available, Medicaid and government money to treat addiction in Kentucky, a lot of it was devoted to these facilities that are maybe inpatient or residential or whatever, and they have these beds. You would go there for 2 weeks or whatever till the money ran out, I guess, and then you would be let go back into the community without the continuity of care. What's going to happen now is that the Medicaid funding will be cut for a lot of these centers, so they will go out of business. So now we're not going to have the beds or the ability to pay for these centers that otherwise were open in communities and out in rural areas. So we have to have our primary care doctors to pick up the slack. And that's why we really want them to feel comfortable doing that. Because you should not have to go to a residential center every time you have an issue with an opioid problem. You should be able to go to your primary care doctor and get some treatment there. And as far as I know, you're still going to be covered at your primary care doctor. That's going to be okay. And Medicaid's not, I don't think they're going to stop covering buprenorphine in certain, formulations. So there's going to be treatment available. It's going to shift. It's going to need to shift from these centers that were inpatient to the primary care. And again, another analogy here. Everyone with a cough and a fever doesn't need to go to the ICU for treatment. They usually go to their primary care doc and they get assessed and they treat them based upon what they need at the time. So they might give you a penicillin shot and some cough medicine and check back with you. They don't admit you to the ICU. It's very expensive, unnecessary. So that's the way it is with addiction. Most addiction can be treated initially at the primary care level. And that's why we need to lower those barriers, have enough funding and regulatory barriers removed so our primary care force can feel comfortable and motivated to treat this medical disease.
Well, how will the primary care physician or addiction specialist decide which patient needs the IM injection, which costs a lot more, versus the PO injection? Medicine.
Well, a lot of it's based upon where you are in terms of your recovery. If generally speaking, you have to demonstrate that you are doing well, or you can take the Suboxone, the buprenorphine orally or of that nature. And if you're doing okay in that way, and say you're somebody who just can't go to the pharmacy, you live in an area where you can't get there once a week to get your medicines refilled. You are also, maybe you're working somewhere, you can't take off work to go to all these visits and go to the pharmacy and get these pills over and over again. Maybe you're somebody who just doesn't do well taking pills. But it's based on the individual characteristics. You might be somebody that would do really, really well with a once a week or once a month injectable. So if we find somebody that we determine that that's a good option for you, we should be able to offer that to somebody. And right now, it's very, very difficult to get an insurance company to approve those injectables. And part of the reason is because they're not generic at this point. They're all out there. To my knowledge, they're all branded, trade name. That may change in a few years, but they're kind of expensive. But it's also very expensive to have somebody relapse. It's also very expensive to our community, to our society, to have somebody in the throes of addiction. Somebody who's functioning well, who's able to go about their life, take care of their family, go to work, not feel like they have to steal things or commit crimes to support their addiction, not have the medical illnesses, the liver damage, all of the things, the infections that go along with opioid use disorder. If you can have somebody that's getting well, the return on that investment is so great. And we need to understand that and allow that to happen.
Are nurse practitioners and physician assistants able to give these medications, or are they prevented from it, in Kentucky and in other states?
Well, technically, they're able to do it. The regulations in Kentucky are very, very strict, and we call them onerous. They're way overkill in terms of what they require the doctors, the nurse practitioners, the physician's assistants to do. And Kentucky's an outlier. The rest of the country, for the most part, has done away with these regulations. But 10 years ago, Kentucky created a regulation for buprenorphine that is very similar to methadone regulations. And frankly, that's absurd because it is not the same medicine as methadone. It's so much safer. The DEA, the federal government, allows it to be prescribed out of clinics, your family practice clinic. But Kentucky's regulations restrict it, in some respects, harsher than methadone. It just doesn't make any sense from a public health standpoint. But I think there's a lot of fear in terms of we don't want to lessen any regulation on any opioid. Well, it's a case of mistaken identity. 10 years ago, they viewed buprenorphine as just another opioid, and they rounded it up with OxyContin and everything else, and they said we're gonna restrict this, and they overly restricted the Suboxone and the buprenorphine. It's 10 years now. It's time to let that restriction be much less. It doesn't mean that we're going to let anybody prescribe buprenorphine without any guardrails. We have regulations that cover all of the controlled substances. I'm just saying it would be nice if we could prescribe buprenorphine at least as easily as we can prescribe OxyContin. I mean, come on, that makes sense.
Well, I know personally some doctors who refuse to do that because of all the regulations, and I know some doctors who've gotten into trouble with Suboxone, and it's hurt them personally and hurt the community personally because of the overregulation.
Right. I think there are some, there's obviously been some doctors and some prescribers that have done poorly and done it wrongly. And by doing that, they make it bad for everybody else. But by and large, most physicians, most nurse practitioners, most PAs, they're doing it for the right reasons. They're trying to help people. And they should not be penalized just because there are a few bad apples out there. And the doctors, I know of other doctors that have tried to do it just the right way, exactly the way that they've been taught to do it, and have gotten in trouble with the medical board. That gets out in the community, and when we find out about that in the community, that makes everyone say, I'm not going to risk my medical license to prescribe this. I'm sorry, I'm just not going to do it. That is so sad. And we can make a change on that. And there was a bill in Frankfurt last year that made it all the way to the last day, and it's going to come up again in 2027. It's going to come up again this next session. So we all need to get behind that and get that regulation for buprenorphine lessened so that our primary care docs and the docs in Kentucky and the nurse practitioners and the PAs can treat this epidemic in the most effective way possible.
How much of an issue is drug use, addiction in the homeless population? And then the next question is, how do they get treated? Is there a way to get access to care for these homeless people who are living under bridges and sleeping in parks and places like that?
Yeah, well, I think that a lot of the reason why people are there in that condition is because there's untreated illness, and a lot of it is untreated psychiatric illness and untreated or poorly treated addiction, for example. So if it's addiction, we need to take the treatment to them. And there are programs. There was a pilot program in this state, in Louisville, in fact, for a while. I think it's stopped now. But in other states where they have had even vans or medical facilities that have gone to these areas and assessed people, decided if they're a good candidate for it, and if they're willing to try it, then start them on the Suboxone right there, at that point. And if you can treat the illness that's causing the behavior, then the thinking becomes more rational and reasonable, and then they can make better healthcare decisions for themselves. So I think there's a dual issue here, a lot of psychiatric issues that need to be treated, and then a lot of addiction, and a lot of them go together. But if they're not going to come to a clinic, and they're not going to come down to Floyd Street and go to the U of L, for example, at the family medicine clinic, we have to go to them, because there's a benefit to society for doing that. We're not just treating the individual, which is the compassionate and humane thing to do. Nothing wrong with treating the individual, but by doing that, we're actually helping solve the problem. We're helping solve the death, the disease, the homelessness problem, the houseless problem, by going to them. And I really think that's the benefit outweighs the risk, and the return on that investment is great.
Okay, this is a 5-minute warning, so we're getting close to the end of the program here. Gene, you want to ask a question or two, and then Paul, Pat, we're going to give you an opportunity to make whatever final comments you might want to make, and then Paul's going to take us out.
I have a question that's bugged me for a long time. Is you remember back in the 90s, Joint Commission had this big deal that pain is a vital sign, and that high emphasis on treating pain. All the nurses had to. That was one of the first questions they asked: how much pain are you having? Do you think that effort was overdone and contributed to some of our addiction problems that we have today?
Yes, definitely. I think that for one, pain is not a vital sign. Pain is subjective. Pain is an individual person's level of misery or discomfort. So, putting a number on your pain is really not a vital sign like a blood pressure or whatever. But the idea that we do need to take pain seriously, though, is very important. So I think you can have a movement where you're addressing pain, but when they called it a vital sign, I think that they opened it up to misinterpretation of what that number really means. And then it was also hijacked, in a sense, by some of the marketing companies and things of that nature. In fact, the Joint Commission would penalize hospitals if they didn't get those pain scores down, and so that contributed to overprescribing. So I think that was initially an attempt to do the right thing, but again they kind of overdid it, and it led to overprescribing.
Pat, you want to make any last-minute comments to our listeners before Paul winds us up?
Well, the most important thing I think that people need to know is that addiction with opioids is a medical issue. It's a medical disease, and there is medicine that is proven to be very effective for this medical illness. We have to have people get access to this medicine. Otherwise, we are not going to get on top of this epidemic like we really need to. It's never going to go away unless we give people access to the treatment that's available, that's effective. We need to remove as many barriers as possible. There are insurance barriers, there are stigma barriers, there are other social barriers, and there's regulatory barriers. So if you want to know more about it, I would say go to a couple of websites that are good about Kentucky issues. The Kentucky Society of Addiction Medicine has a lot on this, so you can look that up. A group called dream.org. They are very active in this, and I would recommend that organization. Also, PAR, People Advocating Recovery. They have a lot of information on this too, but please learn more about it. Please ask questions about it, and then when the time comes to have this bill again about the regulation in 2017, please contact your legislator and tell them that you support the bill to lessen these regulations.
Pat, thank you again for coming on. This is really an excellent program. Paul?
Yeah, Pat, you might give a nod out to your website, which is a very good resource.
Oh, okay. Well, it's jamespmurphymd.com. So that's a blog that I put out. jamespmurphymd.com.
I tune in there quite often. I kind of adopted your cause here a few programs back, and I'm still behind you. Great work.
Thank you.
And thank you, listeners, for tuning in to today's program. Join us the next time for Single Pair Radio, and have a wonderful rest of your day.